Welcome everyone to today's webinar, How Technology Can Help Create a Calming Environment for Pediatric Mental Health Emergencies. On behalf of Becker's Healthcare, thank you for joining us today. Before we begin, I'm going to walk through a few quick housekeeping instructions. First, we'll begin today's webinar with a presentation and have time at the end of the hour for a question and answer session. You can submit any questions you have throughout the webinar by typing them into the Q&A box that you see on your screen. Today's session is being recorded and will be made available after the event. You can use the same link you used to log into today's webinar to access that recording. And finally, if at any time you don't see your slides moving or have trouble with the audio, try refreshing your browser. You can also submit any technical questions into that Q&A box. We are here to help. With that, I am pleased to welcome today's presenters. Gary Kaiser is the Senior Vice President and Chief Marketing and Experience Officer at Children's Health in Dallas. Geneva Burnap is the Senior Director of Emergency Services at Children's Health. And Renee Phillips is a Senior Consultant in Clinical Optimization at Phillips. Thank you all for being here today. Renee, I will now turn the floor over to you.
Thank you, Molly. We really appreciate this introduction. Before we get started, I wanted to just kind of go over our agenda. We're really going to start with a story that helped Children's Health decide the need that they needed at the time. We're going to talk about the pediatric mental health crisis, which I'm sure many of you are experiencing at this time. Then we're going to focus on the collaboration as well as that co-creation between Children's Health and Phillips. And then we're going to highlight some of the preliminary results that we're finding. Carrie, I'd like to turn it over to you to tell us a little bit about Children's Health.
Thank you, Renee, and thank you to everyone at Becker's for having us here today to talk about this. We appreciate speaking and sharing with you today. At Children's Health, we are committed to making life better for children. That is our mission statement, and that is literally the mission that we live each and every day. It also informs our experience intention, which we say is to make life better for children, for those who love them, and for those who enable and provide their care. Those aren't just words. Those are really how our organization is guided in our work each and every day. We are one of the largest and most prestigious pediatric healthcare providers in the country and the leading pediatric healthcare system in North Texas. We care for children through more than 750,000 patient visits annually. We are a multi-facility pediatric health system, and we also house one of the very busiest pediatric emergency departments in the nation. Right now, probably like many of you, we feel like what was once a very busy pediatric ED is a very, 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 very busy pediatric emergency department, treating absolutely unprecedented volumes of children with RSV, COVID, and as I suspect many of you are also dealing with behavioral and mental health issues unlike anything we've seen in the past. Next slide, I think I have to click. As Renee said, this all begins with a story, which is a very personal one for me, but it started a little before that. I was rounding in our emergency department and saw a little girl who was being held. We had several dedicated behavioral health observation rooms, and she literally, we don't want to, say this phrase always, but she seemed to me she looked like an animal in the zoo because she was behind a sliding glass door with everyone just watching her. I was told she was quite young, I believe 6 or 7. She was extremely violent and had a vocabulary that was reflective probably of a very, very difficult upbringing and challenging personal situation. So they had to keep all the rooms around her empty and minimize any kind of interaction with her. To keep her safe, there was nothing in the room for her to do, no toys that she could play with, barely any staff able to really interact with her because she was just so aggressive and so violent. In addition, she was in CPS custody, so there weren't any parents with her. She was all by herself in what was a very bare and sad room. And staff said, they just had a little hope that there was placement for her because of the severity of her age and behavior in terms of what kind of a behavioral health facility we were going to be able to send her to. So she was on a very long stay in our ED. And it was absolutely heartbreaking. Right about that same time, within days of when I was rounding, I started receiving texts, emails, and calls from a couple who are some very dear friends of mine whose daughter began holding in our emergency department as well after her therapist had recommended that the family bring her to us to prevent her from any further potential self-harm. They were desperate for my help in finding somewhere she could be admitted. Dallas and the North Texas region, like many of your regions, I suspect, has a real dearth of available inpatient pediatric behavioral and mental health facilities. And so this child, my friend's child, just like so many of the children we'd seen, like the little girl I'd seen just days before, was being held in RID for several days. She was technically safe. We were going to keep her from hurting herself or hurting anybody else, but she was becoming worse mentally by the moment. Her parents could see it and feel it, and they weren't being given a lot of hope that we were going to find a bed and in this hold anytime in the near future. They were relaying to me how depressing the situation was, how depressing the room was where she was being held, wanting to know what could I do to help them. And I felt incredibly helpless. Sadly, there really wasn't. She was having the finest care. She was safe. She was absolutely safe. And sadly, yes, that horrible room that to me often looks more like a jail cell than a pediatric hospital room was the very, very best that we could do. And I thought, surely we could do better. We had to do better. It was all just very heavy on my heart. And about the very same time, our, at the time, CIO, Pamela Aurora, who has a long and close working relationship with Phillips, had taken a team of us to Phillips to look at the different innovation and capabilities that they have. We didn't go there looking for any particular solutions. We were just there to kind of look at and absorb and think about what they had. One of the solutions we were able to tour and discuss was the NICU of the future that they have in their lab, which featured an array of solutions that were brought together, including the Ambient experience we're going to talk about later, all of which were designed really to improve the experience of the patient and family, improve the outcomes, and minimize the stress in a NICU, which is naturally a high-stress, anxiety-laden situation. This, of course, is, as I said, all while I stay with the little girl fresh on my mind, still getting texts from my friends about their daughter's situation. And I kept thinking about all that Phillips had put together to minimize the stress on the infants that would be in a NICU, as well as the family members, and thinking, what if? What if these solutions work in a NICU environment? Could it work elsewhere? Could these things be adapted or tailored? And I kept asking the Phillips team, I think badgering could be a better word, but I was asking them, have you ever used this with behavioral health or mental health patients? While they hadn't directly done that yet, they did note that some of the elements had been used in more of a geriatric facility, and they did think that it minimized some of the anxiety and agitation in those patients. That's all I needed. That was a big aha. So I asked if they would please consider, just please, taking on an initiative of coming and looking at what we had and thinking about what they had, and could we collaborate to see if we could design a solution tailored to our ED setting, specifically to see could we improve the experience, or could we maybe minimize the agitation, some of the violence, the aggressiveness of the pediatric health patient. What could we do? And that was the what if I was looking at. Geneva, do you want to share kind of where we were at with our ED at the time?
Yes, because I was here in our ED, not that I was jealous, but while Carrie was in Cambridge, I was in Dallas working with what seems like a never-ending construction project in our emergency department. And as you can see on the screen, we were moving from the rooms that Carrie described to something like this. And we were using what I know many of you realize is the garage door technology, a safety feature to put the room equipment behind a door that will come down and secure. But as you can see, this room would not be pleasant for anyone to stay in for more than a few hours. If we were able to decorate it for the 6-year-old that we mentioned, it would certainly not be appropriate for the 15-year-old who might be the next patient in the room. So we were left with, we can improve safety, but can we really improve the experience?
All right, thank you, Geneva. Before we complete a little bit more information regarding the pediatric mental crisis, we did want to have a time to do a poll. So how many dedicated rooms do you have for your behavioral health patients in the emergency department? What type of behavioral health or how many behavioral health adaptive rooms do you have? 1 to 4, 4 to 8, or more than 8? I'll give you guys a few minutes to go ahead and answer this. We'll look at some of our answers. Pretty unanimously, almost, about 1 to 4 is pretty typical, and that's what you guys have built at Dallas Children's, correct? We have 3 rooms live right now, but you have 1 planned coming up, correct, Geneva?
That is correct. And of course, as all of you probably also do, we make rooms safe. We do what we have to do. This morning, I came in and we had 10 behavioral health holds, which is not unusual. Worst case is 27. That has been my greatest challenge. I'm not going to read these statistics to you because if you joined us, you're living them just like we are. But probably scenarios that are familiar. We have someone disruptive in a school classroom. The school doesn't know what to do. They are sent to Children's. I'm sure some of you have adult children who just don't know what to do with a parent or another loved one, so they bring them to your emergency department. Children's prides ourselves in providing the right care at the right time in the right setting. And prior to our work with Phillips, it was so frustrating because for this population in our emergency department, I felt like I was doing none of that. So we had Carrie's idea presented, people were very interested, but then it came to the part that I really enjoy the most, which is operationalizing something and making the case for it. But I got some pushback because people were saying, Geneva, it's 4.5% of your population. Is it really the most urgent issue that you seem to be saying it is? And I said, well, of course it's the most urgent situation. But I knew it was more than 4.5% of what was our work in the ED, but I couldn't figure out how to show that. And I realized that the tools we use to provide our metrics in emergency departments are not designed for the work that we're now doing in our emergency departments. So my tools were only counting every person that came into the ED because the tools were not designed for patients staying days and days. So with the help of my wonderful analytics team, I was able to show the actual care hours that we were providing were 20% of our work. So 4.5% of what comes through the front door, but 20% of all of our hours of care. And that was a great moment for all of us to be able to quantify better what we were actually facing with our work. When I got those statistics, I was able to also show that the average turn time for a room in behavioral health far, far exceeds what we count on in our medical patients in the emergency department. So that problem with throughput meant that I had not cared as appropriately as I could have for over 12,000 medical patients seeking emergency care in the first half of 2021. I also faced the fact that staff were very unhappy. The staff satisfaction was quite low. They didn't feel trained to care for behavioral health patients. They were hesitant to talk with them. They just didn't know what to do. So now we're going to move into a little bit of post-implementation where our staff now feel comfortable interacting with patients because they have the means to do so regardless of the age or condition. And at the end of our implementation phase, it was very exciting to meet all of our goals. We now were supporting de-escalation. We could support active relaxation for the patient, decrease our use of sedation, decrease our use of restraints, and reduce our length of stay.
Thank you, Geneva. So we do have another poll, if you guys would participate. We have, what has been the most valuable initiative that you have implemented to improve patient throughput of mental health patients? One of those choices there. We all go through different initiatives during our emergency department, and what would be the most valuable that you have actually implemented? Nice variation of answers here. We'll move right on. Before we get into the actual collaboration and co-creation, I did want to mention just a little bit about our Phillips team. We're part of the Healthcare Transformation Services, which is a consulting business within Phillips. We do have consultants in the U.S. as well as in 7 different countries. We collaborate with leadership and staff to streamline workflow efficiency, improve utilization of resources, advise on technology strategies and integrations, and design an exceptional experience, just like we did with Children's Health in Dallas. So when we're looking back at some of the goals of Children's Dallas, what they wanted to focus on, some of the positive distraction, the active relaxation, and de-escalation, we realized we already had this existing technology. The Phillips integrated solution has been utilized in multiple sites around the world, and it's designed to enhance staff and patient experiences. The Ambient experience solution utilizes projections, sounds, cove lighting to really create that relaxing environment that's been in many of the hospital settings and many of the clinical areas. As we're researching and looking at the vision of this behavioral health adaptive room, we recognized a third-party provider called Reconnect. We identified that they already had some solutions that focused on mental health using innovative technology. They have a very high security screen. They have multiple apps on them. These apps allow patients, providers, families to really connect through playing games such as tic-tac-toe and also relieving stress with a friendly game of whack-a-mole. The technology also integrates our Phillips Ambient experience into the touchscreen, which allows the patients and families and staff to relax with the projections and sounds within the behavioral health room. You'll see that there is a steel frame that surrounds the glass panel, and a lot of questions that we get is how safe is it? And it is very resistant to extreme violence, and it also meets the stringent safety standards, whether it's Joint Commission or psychiatry. Our collaboration between Dallas Children's and Phillips continued into 2019. We had Phillips consultants on site to really assess the current workflow of the ED and begin that co-creation session of creating a solution that was really about the voice of the staff as well as the patients and families. The key stakeholders really helped to develop patient typologies and solutions that would support the behavioral health clinical environment. We also created a mock-up room that allowed these key stakeholders to really experience the orientational themes and provide some feedback to the solution. And you can see the many quotes there that we collected when we were on site. So this is the first rendering of the behavioral health adaptive room that includes our ambient lighting, our orientational projections, as well as the sounds. You'll see the patient interactive touch screen that allows the patient to have control of the ambient experience, as well as the games and the other applications. To the left side of the screen, you'll see there's a staff tablet. It's outside of the room which allows the ED the ability to have full control of the room if necessary, and it also allows them to use this as a way to reward our patients. And the combination of the Ambient experience along with the interactive touchscreen all help to meet the goals of de-escalation of patients and create that relaxing and safe environment. This is a concept rendering of one of the two themes that Dallas helped us create. And it includes tools which assist with de-escalation techniques. So this is the Summer Forest orientational theme, which has some butterflies that fly in while they're watching. And it's a slight movement there as the butterflies fly in. It actually creates an aid in breathing techniques to calm a pediatric patient. And this one is one of my favorites. It is our second theme, and it's called the Starry Night. It utilizes shooting stars, satellites, and a pulsating star that actually helps to aid in active relaxation. And I love this. This is showing that actual comparison from the concept, the rendering concept that we had to the actual room. So the room on the right is the actual room at Children's Health in Dallas. After the construction and the installation of the room, Phillips consultants were on site to review the current ED workflow again because they had just completed their construction. And then we were helping them to help adapt this workflow to incorporate the integrated solutions. We did multidisciplinary training, and then we had consultants on site to support the go live. And this is a larger view of that final solution. You'll see the reconnect screen towards the left, and which again allows the patient the ability to control the apps. This particular screen is showing you the Ambient experience. So the patient can dim or brighten the lights. They can increase or decrease the sound, and they can also change the theme. The patient within the room has the ability to go through 10 different themes, but the facility has access to all of our over 40 Ambient experience themes. You'll see over to the right side, there's a healthcare provider that is pointing to that breathing or pulsating star and coaching the pediatric patient through breathing techniques. The design of this breathing star is probably one of my favorite stories during our collaboration. It really included the multidisciplinary teams of Children's Health in Dallas and Phillips to actually co-create the whole thought process behind this breathing star. While we only have some preliminary results, I personally have seen how patients love these rooms as well as staff, and staff are really making connections with patients. Geneva, do you want to tell us a little bit about what you're seeing?
Yes, thank you, Renee. So our data will be very interesting, and we've got a lot of great studies planned, but nothing tells you the results like some of the stories that I can tell about actual use of the rooms. We had a patient, it sounds a lot like the one Carrie opened the story with, but it's not the same patient. It just seems to happen a lot. This patient was aggressive. Their underlying condition was not going to allow them to be placed anywhere else. It seemed we were never going to be able to get her in a state that she could go back home. We had closed a 6-area room because she was so destructive and had broken things. At the time, we were not putting aggressive patients in our Phillips rooms, and that was just because of construction constraints with the area. But one of our psychiatrists said, I think she really needs a Phillips room. She had to be restrained on the stretcher to move her to the room. And within 2 hours, we were able to take off her restraints, and by that evening, she was able to be discharged home. It is a story that I will never forget. I often ask if I can office in one of these rooms, but I am told I should really put patient care first. The rooms they are just wonderful. when we were during construction, I would see people come in when we were testing something in the room. They would want to see what the lights were, and when they walked in, you could just visibly see them relax. So I will tell you, you can't truly experience it until you are in one of the rooms, and so you are all invited to Dallas to see them live if you would like. We love to have a big party in Dallas. The last story that I have is this is the email that we received from one of our patient care techs. The manager had walked through. She was a safety assistant. She was acting as a safety assistant for one of our patients. And the manager said, you know, do you feel like you can talk with her? And she was very hesitant. And she said, well, you know, use the Reconnect screen and see what you can do. And as you can see, she was so pleased because she finally did it. She felt like she broke through with the patient. They were able to develop a therapeutic relationship. It made her day as a caregiver so much better, and I know it made the day better for our patient.
All right, and our last question before we go to our question and answer is, are you looking for an innovative solution like this for your pediatric behavioral health patient population? I think most of us are feeling the pediatric mental crisis now, specifically after the lockdown and things that have been going on. So we are definitely excited to share this amazing co-creation. We do have our contacts listed here. So if you have any questions regarding any of the Phillips part of the project or any of the Dallas, we have those listed here. And Molly, we'll turn it back over to you to go ahead and get back into our question and answer. Thank you all very much for your time. We appreciate your interest, and we look forward to seeing your questions.
Wonderful. Well, thank you, Carrie, Geneva, and Renee, for such a great presentation. Attendees, we will now begin today's question and answer session. You can submit any questions you have by typing them into the Q&A chat box that you see there on your webinar console. And let's get started with the first question. That is, let's see. Oh, okay. An attendee would like to know, are these rooms for the emergency department only, or can they be used for other behavioral health type rooms? Renee, you might be the best person to speak to this one.
Sure, yes. Definitely. We have different variations that can be used, whether it's in an inpatient room, the ICU, as well as the pediatric or adult emergency department.
Perfect. Thank you, Renee. Carrie and Geneva, I think this next question is probably, I'm going to combine a couple. They're curious about what resources you have available in your ED. One attendee would like to know, do you have child life specialists in your ED? And another attendee would like to know, do you utilize behavioral health navigators or advocates? And if so, are they staffed 24/7?
Yeah, this is Geneva. Those are great questions. We are fortunate enough to have child life in our emergency department 24/7. For our behavioral health patients, we have a medical assessment team, or the MHAT team, and with that subspecialty group, they do also have folks that are dedicated just to the search for outside rooms.
Terrific. I'm going to stay with both of you for this next question as well. We saw that attendees put that most of them have 1 to 4 rooms dedicated for behavioral health patients in their ED. One attendee would like to know, if you were going to rebuild your emergency department, what proportion of behavioral health rooms would you recommend compared to the total number of rooms?
This again is Geneva.
I was going to say, Geneva, you may be best. No, I was going to say, you may be best to answer that, but...
Yeah, if I was only, trying to differentiate for the behavioral health population, you saw that I determined that's about 20% of our work, so I would do 20 to 25% of the rooms. However, in a perfect world, this would be in every room, because it's not just about the behavioral health patients, it's not just about the children. when I see the impact on parents, when I see the family, again, this just visible relaxation, and my peers on the inpatient side who have families who stay a long time, that was their first comment. I wish our families had this. So I'm an advocate for every room, including my office, remember, to have this capability.
Terrific. So you said that the analysis showed behavioral health patients made up about 4% of people coming through the doors, but like you said, 20% of your time and your team's time. So therefore, you would recommend 20% of rooms have these capabilities, but ideally all. Terrific.
Correct. Yes.
Another attendee would like to know, what is your patient criteria to use these types of rooms for patients? Do all patients get access to this room?
No, first it is any behavioral health patient, unless, and that day has not come yet, that we had none. But as far as differentiating between them, we're just too busy to hold those for a certain subtype of behavioral health patient. So it is really just first come, first serve. We will have patients that once they are here and in that area, we'll say, can I be in that room, as soon as it's empty? And we've also done that, because that means they will have had hours in a room that it does not have the ambient experience, and it's time to get them something that's a little more stimulating.
And this is Carrie. I was just going to jump in and kind of second on one of the reasons we're working so hard to gather the data so that we have more data and really look at and document these outcomes is to what Geneva's alluding to, that we see that there is efficacy and potential in using some of these solutions outside of, not just the behavioral health rooms, but other rooms in the ED, as well as other areas. We have the CCBD, Cancer Center and Blood Disorders, where you have very long stay, and how might some of these kinds of components be used for the Heart Center. Any of those really long stay places. Again, this originally started in the NICU of the future that Phillips had, which is another long stay, high stress area. And so, as we get the data and as we really see what happens in these rooms and the kinds of outcomes or results, it's going to help us better inform, because as Geneva said at the beginning, we have to build the business case to say, we think there's potential elsewhere for how we could use these.
Absolutely. And Renee, you can probably speak to the number of scenes. We showed 2. But there are many, many scene choices and audio choices, including if the child can plug in their iPod to have their tunes if they would like that. But my favorite is Under the Sea, and there's a theme and a scene for everyone's taste, which I think is one of those things that just the ability to personalize it that's what just makes it important for everyone to have access to it.
Perfect. So we got some sense of what criteria for patient use of these rooms, but on the flip side of that, an attendee would like to know, do you flex these rooms, these behavioral health rooms, to put other ED patients in them, or are they solely for behavioral health patients?
They are multi-purpose, but so far we have not had the luxury of having less than 3 behavioral health patients.
Okay, got it. Well, we have some attendees are asking about the cost side of this. How much would it cost to outfit one room? So to speak to that, I'm going to welcome Brad Jesse, who's on the line. He's the marketing manager for Ambient Experience. Brad, if you could share some information about the financial side of this and what you would tell our attendees, please do.
Absolutely. Thank you, Molly. And thanks, everybody. Nice to see you all on the call. And the answer to that question is it's not challenging, but there is a cost, obviously, to the room. But because this system is really customized to your particular department and number of rooms and size of rooms and how what your rooms look like now versus if it's a renovation versus a new build, it's really hard to provide an actual cost per room. So what I'm going to say is that the project really needs to be scoped out for each respective customer to determine what that full solution price is going to be. I'm not trying to avoid the question, but it is different in different cases. So if you want, or if you need pricing, please reach out to us at Phillips. You can reach out through Renee or through myself or anybody that you know from Phillips. But if you want some pricing, we can definitely help you with that, and we'd like to really assess your needs first and see how many rooms, is it a renovation, is it new, and do all those types of things before we give you sort of a price for that. So I hope that helps.
Thank you, Brad. Thanks for helping direct where our attendees can get further detailed information on that thought. Well, attendees, thank you so much for your questions. I'm going to now turn it back over to our presenters for any closing thoughts they have before we conclude today. Gary, can I turn to you first?
Yeah, thank you. Thank you very much. I just wanted to thank everyone for joining in and listening. Again, this was really started with a what if and how could we, and we are gathering the data so that we can really document. We believe we've proven the efficacy, but we would like to have the data to document and really look at some of the cost-benefit analysis. But I also want to take this moment to commend and thank the Phillips folks, and not just for such a wonderful solution, but for humoring my what if and my persistence and asking them to come, and really want to commend and kind of call out the process, because I think that is critical for anyone looking to view these. This was very much co-designed using the staff, using the physicians, and patient families. We brought a number of patient families into it, and I think the results speak to the power of the process and the partnership and the collaboration that Phillips did with us to bring this to our patients and families in making life better for children. And so I just want to say thank you to Phillips, and I want to note that I think that doing anything like this without you go slower to move fast, but the process I think is a critical piece of it.
Thank you, Carrie. Geneva, would you like to add anything in closing?
Yes, thank you so much. Thank you all for tuning in. Carrie leads as our Chief Experience Officer all of our leaders at Children's through remembering our gratitude. And I love Children's, I love our patients, and I love our mission to make life better for children. So I just want to express, what gratitude I have. If you can imagine going from that glassed-in room, which was designed to be safe, to this, in a matter, really a very short time overall. We were lucky to already be in construction. My gratitude to both Carrie and to Phillips. I just cannot express enough. It's such a great encouragement for everybody to say, what if?
Thanks, Geneva. And then finally, I'll turn to the Phillips team, Renee, and I'll also include Jesse here for closing thoughts. Renee, let's check in with you.
Great. Thank you. And again, thanks for everyone that joined in today. As the project manager of this project, as well as an emergency nurse for more than 18 years, it was truly amazing to see the co-creation and the collaboration between Dallas Children's as well as Phillips, and to provide this and see the connections and actually see the patients on our Go Live Day was just amazing to see how we're making a change, and how I'm just excited to see the great positive outcomes that are going to come from this. Brad?
Yeah, thanks, Renee. And I would also like to thank everybody who joined today for the call. This is really, for us at Phillips, it really is something that we're very, very proud of. We really worked together with Dallas Children's on creating what we think is a fantastic solution, and we're actually seeing the results of that, anecdotally from Geneva and Carrie. And we know that there is a mental health crisis going on in the United States right now, and we really, warrant and welcome you guys to contact us and connect with us, and if you need help, because we're here to help you. And finally, I just see one question that I wanted to address, and that is, have we used this type of technology in respite spaces? And the answer is yes. And I think if those of you on the phone, it comes up every time we talk about behavioral health. We have a solution already for respite spaces. So if you need that kind of information as well, please reach out to us here at Phillips. And again, thank you so much for joining today.
Perfect. I want to thank again Carrie, Geneva, and Renee for that excellent presentation, and Brad and Phillips for sponsoring today's webinar. To learn more about the content that was presented today, please check out the resources section on your webinar console and fill out that post-webinar survey. Attendees, thank you for joining us today. We hope you have a wonderful rest of your afternoon.